Moving from bleeding to coagulation or clotting, we rely on several diagnostic tests. Some we've seen like APTT, PT, factor assays, and others like fibrinogen levels, specifically fibrinogen levels, fibrin split products, and thrombin time. These tests help us to identify whether the problem lies in clotting factor deficiencies, inhibitors, or fibrinolysis. For example, low fibrinogen suggests consumptive coagulopathy, while an abnormal thrombin time may point to qualitative fibrinogen defects. Together, these tests provide a comprehensive evaluation of bleeding disorders. When we suspect DIC, disseminated intravascular coagulation, we use specific screening panels, which include fibrinogen, D-dimer, thrombosis indicators, PTT, PT, and platelet count. DIC is unique in that it consumes clotting factors, prolonging PT and APTT, but it also lowers the platelet count and fibrinogen. Elevated D-dimer reflects fibrinolysis. Because patients with DIC are clotting and bleeding at the same time, lab evaluation is crucial for diagnosis and managing treatment. The D-dimer test identifies evidence of intravascular clotting. It measures fragments produced when cross-linked fibrin is broken down by plasmon. Clinically, we use it to evaluate for conditions like pulmonary embolism, deep vein thrombosis, and DIC. While it's sensitive, it's not specific. That means a negative D-dimer is very useful in ruling out clotting disorders, but a positive test requires additional evaluation. Normal findings for the D-dimer are less than 500 nanograms per milliliter fibrinogen equivalent units or FEUs. Um, these cutoffs are widely used in the emergency medicine scene to rule out thromboembolic disease, DVT-PE. However, interpretation must always consider the clinical context. A mildly elevated D-dimer in an older patient or someone with infection may not necessarily indicate a clot. That's why D-dimer works best when combined with clinical scoring systems like Wells criteria for DVT or PE. And therefore, we have here an example of when evaluating for a pulmonary embolism, we use a combination of tests. Arterial blood gas could show hypoxemia and abnormal CO2 levels. A CT angiogram can directly visualize the emboli in the pulmonary artery. A chest x-ray could show enlargement of the pulmonary arteries. EKG might reveal the classic S1Q3T3 pattern, though it's not always present. Echo can detect right ventricular strain. D-dimer is often elevated. Finally, a vent perfusion scan or pulmonary function testing can reveal mismatches and impaired diffusion. Together, these tests help to confirm or rule out a PE. But like other coagulation studies, D-dimer results can be influenced by interfering factors. Lipemic samples may falsely lower D-dimer values. On the other hand, rheumatoid factor, especially when greater than 50 international units per milliliter, can falsely elevate the result, which is why we must interpret D-dimer carefully, considering the whole picture. The collection pattern is the same, non-fasting in a blue top citrate tube. And when it's increased, it's associated with a whole host of conditions. It's not really good at honing in on one, but they are all involving clot formation and breakdown. So this could be DIC, primary fibrinolysis, thrombolytic therapy, deep vein thrombosis, DVT, or pulmonary embolism, and arterial thromboembolism. It also can be elevated in sickle cell anemia, pregnancy, malignancy, and post-surgical states. While this range of associations makes it really non-specific, the test is valuable because of its sensitivity. It almost always rises when there's significant clotting and fibrinolysis. So if you suspected a clot, got a D-dimer, and it was negative, you could rule that out, which is reassuring. When we come back, we'll specifically look at fibrinogen, factor one, its assay, and its importance.